transition into our sort of audience participation part of this by giving up my seat to Steve, if you'd like to come up here, and he can answer some questions at the same time as you ask them. But I'm going to get up and maybe facilitate this next section with you guys as the audience to have you ask questions of the panel that are both related to the questions that I was asking, or perhaps their presentation that they were giving. The short presentation that they were giving, but also ask questions in a constructive manner that help us design what both the curriculum and the delivery looks like. So I think Steve and team are here, and they've been one of the main things that we've been pushing for on the steering committee is the development of the curriculum. And as we started to assemble experts and expert data, we know we had a lot of information to deal with. And what Steve has done, without necessarily being a big data expert, but an education expert, is help us assemble that into a curriculum. You saw at least the draft of it, and you've already given us some feedback. But based on the experts you have here, and also Steve in the execution element of it, as well as the rest of the steering committee in the room and the Reagan-Udall folks, please ask your questions in ways that both clarify what you want to know, but also what you would think that others like you would like to see at training like this. Anyone want to start? Yeah, or I saw some questions actually coming in, and Alicia, I don't know if there are questions that came in online, or if you'd like to ask them on behalf of those online, you're welcome to do that as well.
So this question came in earlier, so it isn't meant for any particular panel member, but is really both a question and concern really on how this program and how this program will address ensuring that big data is not used to further marginalize populations that are already on kind of the extremities, and really addressing the reality that some or many people that data is collected on will not be direct beneficiaries of our ultimate goals and really overarching benefits that we see big data contributing to health research. So really, how, I guess, does this program envision trying to connect the different pieces and ensure that disparate populations of patients aren't further marginalized?
Let me see if I have the question right, and then perhaps who might be able to answer it. And I think while Amy gave the general curriculum of day one in her part one of her answer about what data are being collected, perhaps Amy, I don't know if you want to comment on this question first, but anyone's welcome to do that as well, because I think one of the elements that I know the less initiated, those that are asking questions about what do data look like and where are they coming from, are asking questions about its privacy, its use, can I be identified, et cetera, et cetera. And so I think some of the things that were mentioned here is that you can do it, but what is the patient's role in both protecting that but also releasing some of that information?
So I'll start, and as I think about this very important issue, which is how do we make sure that the rise of big data actually helps to solve for issues of disparities, not worsen it. I mean, part of it, I think, is going to come back to, I look at Steve, making sure that we're thoughtful about embedding in the curriculum exemplars of how understanding from large-scale representative data can help us understand what's going on for populations. I'll tell you, one of the things we're seeing right now is, now that we can see 20% of what's going on in cancer across the U.S., we're starting to see patterns of disparate care that, as an oncologist, make me scratch my head and say, we need to do something about this now. And then the second part of this maps back to the program to say, we learned something, how do we quickly shift that to action? And I think that's also part of the curriculum.
That's great. Good.
Yeah, I think the other thing I would just add to that is that I think the curriculum itself does need to attend to the available data sources that could actually illuminate those populations that might not be well represented in some of the larger data sets. So I think, again, really paying attention to what are the potential areas we could be going to illuminate some of those voices that aren't being well heard, but also that are given them the opportunity to also increase their ability to be an advocate for that more marginalized community. So.
Yeah. Jane, no, 'cause both of you had a comment.
So I think for PCORNet, and the advantage of being a non-profit organization is that we were able to invest in communities that traditionally have been underserved. So on our clinical data research network, we have a whole community of federally qualified health centers that are part of the system. And on our PPRN side, we have a number of traditionally underserved communities. One is they're called CPPRN community, PPRN, and they actually serve minorities in LA and New Orleans that have struggled with mental health disorders. But their model is it's hand-to-hand combat. It's through churches, it's through schools, it's physical relationships that are being built with these communities and working with them, building the trust, and then giving back research results. That may or may not be scalable to other kinds of diseases and conditions, but we're sort of learning from these models. But it's a really critical question about how you ensure equity as well.
Yeah, and I would make 2 points. One is, I think one of the red flags that I mentioned that you should train all advocates about is the sensitivity of this very issue. And we do it within the case studies and other things. What are the questions within big data to say, are these data representative? Do we have the right people? And I think, effective advocates raise those issues much more than scientists do on average. And the other thing is, I think in our recruiting in our case studies, we should try to go out of our way to actually have some of people who are from that community. And I think PCORNet is probably a really great resource, both maybe using a case study and getting some of their less representative active people to be part of this.
So I'll just add that this has been a conversation within our own group about how big data actually does provide an inherent advocacy for unique and special populations, where in a clinical trial you might only get 1 or 2 people from a certain special underserved population to participate. And you can't really, that person's data really does become lost. But in a big data trial, if you have 430,000 people, you're very likely to be able to do the sort of science that allows for understanding of underserved and smaller subgroups within a population. So I think that's certainly something that we want to spell out within the curriculum, is that benefit to big data. But also, on the flip side, that advocates can help describe the potential for participation in these sorts of studies, so that underserved communities feel more comfortable and see the value in participating, that it goes both ways, and that they need to participate in order to get that benefit out, but that the nature of these studies lends itself to positive outcomes based on participation. So we're certainly open to how to improve that message throughout the training program.
Yeah, questions from the audience. Cindy, you're welcome. So those both online and in the room, please ask. These are not only our steering committee members, but they're our data experts as well. So these are likely to be what the faculty will look like too. So if you're going to be asking questions from your chair at this particular training, please ask those. And those types of questions actually helps us develop not only the curriculum and the content, but how those questions should be answered.
Thank you, and you could tell I've given a lot of this stuff a lot of thought for, I guess maybe just I don't have enough else going on. But the question, another question related to what Jane said and also came up about de-identification and privacy. Nobody has mentioned anything about genomic data and the kind of data that's really, really, really hard to de-identify, and the fact that this training might kind of come in tandem with the recruitment for the precision medicine initiative in a kind of public outpouring of volunteer or solicitation for volunteers to get 1 million people to donate everything they see, eat, do, wear, anyway. So is there, it's a big question, but I think it's something that probably needs to come in here, and potentially the PMI could be, an example.
That was part of the reason that 23andMe was selected. Brad Smith, I think, and I had a side conversation around the issues with 23andMe and having to carefully constrain that discussion around that case to core principles. But it does provide a nice opening to the use of genomic data. That's my background as a scientist, actually, is genomics, and recognizing that after I collect only so many bits of data, I can identify you if I have a genomic match. And so it does provide an opportunity for those discussions, and that genomic data is now so inexpensive relatively that within 5 years that will become a common part of medical records. So it lends itself well to big data questions, but obviously is intertwined with those privacy issues as well.
To the PMI question, we talked about that as the content work group. But the problem right now is that the decisions are changing so quickly. Between one monthly call and another, there's been huge changes in what it's going to look like, who's doing what, all of that. So it was really hard to think of it as an example that would be used for 3 pilot trainings that wouldn't change so much that we'd have to rework the entire thing. So everyone's very aware of it, and I think probably maybe in discussion or something like that we should work it in, but as one of the core case examples, that was the reason it wasn't included.
You know, the more I hear this discussion, the more I realize that I mean, a lot of us have been thinking about this for a long time, and we want to use this, you know, like cutting edge example, but I think the truth is that maybe things like warfarin dosing or BRCA2 tests, where we have a long history of understanding how this has benefited decision making for patients that has really improved health, are better. And although those seem commonplace, I think they're not commonplace you know, across America. And using those examples where we're not going to find out something in a week that changes everything, and that the person who went through the training is now the deer in the headlights, but something that we feel like this is not going to change in the next year or two. We're training you to give this nice example of how genomic information can help. May be the better path to go down.
Thanks, Seal.
The case that they're more likely to be asked to be on some subcommittee for the PMI where we don't know the answers, but getting them grounded in the examples is very reasonable.
And the one thing I was going to add is that it strikes me one of the tasks of BD4P is starting to create a community of advocates who know the foundational basics, because we're going to all need to make sure that this conversation is evolving quickly and has patients very much involved in it. I don't think that we're going to be able to do this without them.
Yeah, no, that's right. And there's some great examples of this in the advocacy community of much of what we've been modeling, some of the curriculum and delivery about teaching people about clinical trials or about advocacy in general, both on the patient side and the policy side. So there's a lot of great examples out there that have built armies of advocates that can speak about privacy-related issues, about minority-related issues, about what you can use these type of data and data projects for. Is there a place where you can start asking questions where you might not be the data scientist, but you may have a particular disease-specific question that you want to ask 110 million different patient collection of data. So there's a lot of things that we can teach to get people, just to push them over the edge a little bit to start asking those questions. So the more people we teach in a pilot, if we get to 80 people, as Steve said, that's great. Then they'll tell 2 friends and so on. That's the whole idea here. Additional questions? Steve,
I would just follow up to say that if in our perfect world, people who walk out of here will have engaged with 4 cases. They will easily be able to forget the names of those 4 cases, but the principles underlying those cases will be what they carry forward, and that they'll be able to apply that to any story. And so if PMI, hopefully in a year or 2, becomes more solid and clear, that they'll be able to come in with that and say, I understand the privacy issues. I understand the data access issues. I understand the data cleanup issues, because I remember engaging with those, and I don't remember which cases we did, but it was an education tool rather than knowledge about that particular case. So we're certainly open to changing the cases. We're envisioning each of those not because of the case, with all due respect, but because of the underlying principles that are emphasized within different cases.
Great. Other questions from the audience or anything coming in online? Okay, so maybe what I'll do in the last maybe several minutes, and I have some closing remarks as well, is maybe ask the panelists for sort of their perspective on if you were to ask a question as a faculty member on a program like this, and you would want the audience to walk away with a couple of points. I think what Steve just said may be his answer is, using these case studies, we're remembering principles, not names. But could each of you maybe comment on what you would like the audience to take away from something that you would teach them? And you have the mic.
I have the microphone first. Here we go. I think that the number one thing that I would want to make sure the audience can take away is, where do I go to get additional resource? I actually reflect back to one of the best PCORNet meetings I was ever at. I had the opportunity to be a part of PCORNet before I came to Flatiron, and it was like 2,000 people in the room, and people were at all these different tables, and it was essentially Brownian motion and then some Van der Waals reactions. And the thing that I left with was, who do I call for what problem? And I think that's one of the things that I would hope people leave with.
That's great.
It's a great question, and I think based on some of the previous conversation, I think what will be important will be for each case study to be somewhat of a demonstration of the values and principles associated with what the point is that we're trying to make. I was sort of thinking about data stewardship, so what are the responsibilities of those people who are the stewards of the data, who may be the collectors of the data? What are we holding them accountable for? And having an advocate feel completely comfortable being able to test that assumption in a role that they may have when they're encountering a research project that's using big data. To be able to say confidently, I'd like to hear a little bit more about the values and principles of your data stewardship policies, or something that sort of says, you must have these, right? These would be important for you to have, and feel comfortable recognizing that that's a question they should ask. So I always think that the underlying values and principles should be transparent, and I think within each of the case studies, I would really like advocates to be able to say to me, if they were asking me about patients like me, what are the core values and principles from which you operate that gives me confidence that the data you're collecting actually does respect the stewardship expectations. So.
That's great.
It's an interesting question. I think Sally made me think about trust, sort of the issue of trust, and sort of building trust in all of these relationships is a key issue. But I'd say, I think overall, for people to come away with an appreciation of the complexity of the problem, and understanding that there are trade-offs between security, privacy, getting answers quickly, what kinds of answers, what kind of depth, and sort of, I think often we go down the rabbit holes of each one, but having an appreciation of the big picture and the trade-offs and the benefits and the risks is important, because that helps us make better choices as to how we engage and when we engage and who we engage with.
So I really like the answer so far. I would say one is push the envelope. Recognize that as a patient advocate in this program, your patient advocacy is not that well formed of a discipline yet, and in big data even more so. So push wherever you can, including, are they asking the right questions? And remember that you're there representing the patient, and there's a sense of urgency. One of my advocate mantras in general is, patients don't have the luxury of patience. So try to push that. And another one of my mantras is, I have to have my say, but I don't have to have my way. And make sure that you're a collaborator, that you do speak up for patients, but you also try to understand what the other stakeholders are, and then feel as though you have a responsibility to communicate back to the public, to your constituency, about what some of the other issues are, what's good and bad about these projects. Be discriminating between, don't get all excited about every last big data project, but try to understand what the specifics are and convey that back.
Jane, that's great. And maybe I'll leave one of the last questions to Steve as sort of the dean of this esteemed faculty, I guess, in terms of your role on the project. Behind you are these 4 bullet points that we've talked about as a team about In this section, I think we've addressed a lot of these so far, and how are these examples applicable, et cetera, et cetera. Steve, I don't know if there's additional things you'd like to ask the audience, both here in the room and online. One thing that Steve did say is keep the feedback coming, and for those of you who are in the room, we know who you are, and we're going to follow up with you because we want your input. And just because there is a steering committee that is helping decide where this is going, we need all of the external parties too. Recruitment, design of and shaping of the curriculum. But Steve, are there additional questions that you'd like to ask that might help you in the next, I guess, how many days you got? 18 days or so? Yeah, to finish this up.
I think I would just reiterate that if I went and queried each of you, we would have a different model for this curriculum. All right, so there are a variety of ideas. The more feedback we get, this is big data, folks, I can start to see the patterns that say, all right, this is where most people are needing information. This is where most people see these advocates requiring information and so forth. So again, I think this has been remarkably valuable for me to hear the different voices and perspectives. That helps us identify patterns. But the more information that we get and the more ideas around strengths and limitations of certain case studies and core content and core concepts that really need to be emphasized, and how to provide resources and how will advocates use this, it will all just go to better inform this. So I just want to emphasize the value of your feedback.
Any additional questions from the audience? Let me just move back here, and I'll excuse my panelists, and they're welcome to go back to their seats. Steve, Amy, Sally, Rachel, and Jane, thank you very much. Please help me thank them. Not only are they, panelists here making trips to Washington, but participating in phone calls and engaging with the Reagan-Udall team, but engaging in their day jobs as well, which is exactly why they're sitting here, is that these are the data experts that are helping us. I also want to thank our Reagan-Udall staff who've been great partners. We as the co-chairs have bi-weekly calls that are incredibly informative, and they're very responsive to what the steering committee drives them to, but also kind of what I drive them to as well. But it's been incredibly valuable. So I just want to close with a few remarks, and I think going back to how we started the meeting and the themes of this particular program, and that a lot of what we talked about is we want the core principles that people understand the meaning of data. And we were talking in the back during the break that, who is it that would benefit from the truckload of information that can be dumped on someone in a didactic way? And most of us have learned our particular skills and data from immersion, not necessarily a didactic classroom setting. So that's exactly what we'd like to do with this, is not to push people to know every element of what data are and what they look like and all the structural elements of data, but mostly about how they're collected and how they're used. Also, how are big data research different from sort of the fundamental research that people and the advocacy community might think in a clinical trial setting or basic science research, and how can we use big data research to help people understand that compilations of data are incredibly valuable. The third theme we talked a lot about is the privacy-related issues and the policy-related issues of using data and where can it be used safely and effectively. And then finally, this is exactly where we want this whole program to go, is the inclusion of advocates in future research. So if people are comfortable asking the question, I think, Rachel said that the door is open, and I think that was a great way to make a comment about how patients can engage. I think all of us are trying to open doors further in the work that we're doing, whether in advocate or industry or PCORNet, for example. Jennifer has some great programs going on now to teach people about how to share information, share it safely, but share it effectively. Amy's collecting all of the data that everyone's using in the cancer space, and they're working very closely with lots of different stakeholders to determine how that can be used. But let me just close with a couple of comments about things that I heard over the course of the day today. And I think the primary thing that I heard over and over again is this application of data and how it can be applied. I think I heard apply, application, countless times today. But I mean, I think what we need to do as both in this particular program, but we as data enthusiasts is keep telling others how this can be done. The intent of this program is to teach people a little bit about how it is done, right? So that's how our data being collected, but also how it can be done by you, and by you as a member of the education, that you can actually start asking some of these questions. From the start of a particular project that I'm continuing to work on, we had countless hours of talking to lawyers about what it means to collect data from a particular area. This is clinical trial, control arm, pretty safe information, collecting it from various places, and mostly from my industry partners, thus the need for countless lawyers. But there was so much groundwork laid about how to collect information on, can you collect it safely, securely, and privately. And then now we're to the point of that it's being applied. But one of the challenges that I see in the project that I'm working on, and many in the data field, is its application to those that are not scientists or not data scientists. One of the things that we have some great prognostic models that are about to be published that have been collected from prostate cancer data. But what I'd like to see is something that helps a patient understand their path through a clinical trial or path through their disease journey. I know that many of the data collection activities that are going on now have that in mind, but the particular project I'm working on, we've fallen a little short about what it means for a patient to go through a particular disease, and we've got the data that can help them do that, and they can help them select that if I start one pathway, I have 4 more pathways to go down, but I know what those are and what that means. So I think that's the application piece. I want to really thank everyone for being here today, both in the room and online. Your input is invaluable. I'll continue to say this, is that our steering committee is absolutely great about giving feedback to myself as the co-chair, but also to the Reagan-Udall team about how this should be done. But we can't do it. So all of us that have been involved in this project we are the converted. We are, we've been going to this church for a long time. So we want those people that have education expertise, delivery expertise, content questions that we know that we need to answer during this particular program. So please continue to give your input. All of us are in this community regularly with the patient advocates, the data scientists, and others. So we need to listen, and we need to pass that back to Steve and the Reagan-Udall team as well. So continue to give feedback on the curriculum, practical feedback. That was another word I heard over the course of the day, is make it easy for people to understand and apply. And then finally, we have had some discussions in this room, but also we need to start immediately on who are the attendees and the recruits that we want to come to this particular program. I think we've helped to identify that these are the initiated, but not the fully converted. And I think if we start there with the pilot, we'll get some great feedback, but also we want to have some sustainability as well. So the steering committee members and I actually have the afternoon to help digest some of the feedback that you've given to us. Keep it coming. Please keep it coming. But thank you, everyone, for your morning, and thank you, everyone, for your input. And please have a great afternoon. Take care.